Good morning, everyone, and welcome to our final lecture for MedSurg 1. We're going to be starting today with the introduction to the immune system. And by the way, you guys did really great on the test. Really great on that test. So a lot of this stuff is just review because we did some of this with the hemopoietic system. So this is just some, like I said, some review, some of it will be. So the immune system is a collection of specialized white cells and lymphoid tissue that maintain the immune system and its ability to cooperatively protect a person from external invaders into the body's system. The function of these structures is assisted by natural killer cells, antibodies, and non-antibodies, also known as your cytokines. So your white blood cells are produced in the bone marrow. You have lymphocytes, neutrophils, and monocytes. Your leukocytes consist of T cell or B cells, and they are the primary function in the immune response. Your white cells manufactured in the bone marrow travel to the thymus gland, mature, and they begin to either regulate the T cell or the effector T cells. Components, you have regulator T cells, helper T cells, suppressor T cells, and effector T cells. So you need to know the difference between these. So your T cell count, 500 to 1500. If you have a T cell count of 200 or less, that patient has some HIV going on. Components of the T cells, you have antigens, which are your protein markers, your antibodies, which destroy foreign agents, cytokine cells, and lymphokines. Your B cell matures in the bone marrow, migrate to the spleen and other lymphoid tissue. Components of B cell, plasma cells, and memory cells. Like I said, this is just a quick review of your basic cell types. B cells versus T cells. So your B cells attack invaders outside of the cells. Your T cells attack invaders inside of the cells. That is the difference between the two. One is for inside, the other one is for the outside. Neutrophils and monocytes. Neutrophils, they're very small in the blood and they migrate to the tissue. They digest bacteria and foreign material. Monocytes or macrophages, they're very large. They also are present in tissue, but more so in the lung, liver, and lymph nodes, spleen, peritoneum. And they may migrate as the cell is mediated. So after the cell's been called into action, these begin to migrate. White blood cells perform phagocytosis. That's a process of engulfing and digesting bacteria or foreign material. That's what the white blood cells count do. So when the patient has an infection, that's why you have more white blood cells producing, is because they're trying to gobble up that infection. These you've already talked about. We already talked about the leukopenia, leukocytosis, neutropenias when the neutrophils are less than 2,000. Someone was asked a question about bands. So here's your answer about bands. You have a shift in your immune system to the infection side there. Neutropenic precautions. We've talked about this in fundamentals. In fundamentals, we talked about having to protect some people that had a really low white count. You have to protect those people. So you restrict those visitors, restrict those live plants, no fresh fruit or vegetables. So neutropenic precautions, and this is just a link to a video explaining neutropenic precautions and how you proceed with those. So what's your lymphoid tissue? It consists of your thymus gland, tonsils, and adenoids. So the tonsils and adenoids actually filter bacteria from the tissue and fluid. Spleen is also a lymphoid structure, and not only does it reservoir for blood, but it also removes bacteria. Both old and damaged blood cells are also produced there. Then you have your lymph nodes. That's part of your lymphoid tissue as well. So the function of the spleen produces some antibodies, and it produces lymphocytes that aid in the immune function. Your thymus gland, as you see, T lymphocytes, your white blood cells, that's produced in the thymus gland. Lymph nodes, we've already talked some about lymph nodes and their role in the immune system. But here's a link to the anatomy of a lymph node if you'd like to watch that. So your natural killer cells, or NK cells, they're lymphocyte cells that circulate throughout the body, looking for any type of virus or cancer cell, because they want to find a virus or cancer cell because they want to gobble those up. The killer cells identify typical markers in the membranes of these cells, so that's what they're attached to. That's what they're looking for, particular markers in those cells. Then they release chemicals that alter the cell's membrane. Cancer cells that escape the natural killer cells cause cancer cells to spread beyond the primary site. So you're looking at metastasis there. Your antibodies. Antibodies are proteins produced by the B lymphocyte, and plasma cells. These are your antibodies. Here you have 5 different antibodies. The immunoglobulins bind with the antigens, promote the destruction of invading cells by hindering the antigens physically, and they either neutralize, link together, or cause them to precipitate or become solid. So this is your antibodies and your immunoglobulins. This is just a mnemonic to kind of help you remember those immunoglobulins. So you have some non-antibody proteins, interleukins, interferons, and then your tumor necrosis factor. These are type of cytokines that help a cellular repair when administered in small doses. But more importantly, we're going to talk about immunity. So first, we're going to start with active immunity. So active immunity is an adaptive process that allows the body to make antibodies in response to the entry of antigens into the body. So a direct exposure by a vaccine or disease leads to this type of immunity. So a direct exposure by vaccine or disease leads to this type of immunity. So you have naturally acquired immunity. And like I said, this occurs as a direct result of an infection, such as the measles. So this is an active, naturally acquired immunity. Then you have artificially acquired immunity. And this is from the administration of a killed or weakened microorganism or toxoid. This is like a vaccine, like your flu vaccine or your hepatitis B vaccine. This is an artificially acquired active immunity, like your flu vaccine or your hepatitis B vaccine. Passive immunity. This develops when antibodies from another human or animal are transferred to the client because the client does not independently develop antibodies. Passive immunity is temporary. So you have natural passive immunity. This occurs when antibodies pass from the mother to the newborn. So this is when the baby develops an immunity from what it gets from its mother. Then you have your artificial immunities. These are artificially passive immunities. And this could be like from a bite or an exposure of some type. These are more passive. So you need to know the difference between your passive immunities, your active immunities, and those examples of naturally acquired and artificial. You need to know the difference between those immunities. So when we're talking about immunity, of course, you get the immunization record because we're talking about a focused immunity, focused assessment, I'm sorry. Recent or past infectious diseases, recent exposure to infectious diseases, drug history, allergy history as well. Then you can look at your physical assessment, assess abdomen for enlarged spleen, rashes, look for those tonsils, see if there's any drainage, because we know that's part of the immunity system. So you're going to do lab tests, you're going to do a CBC, and that's whenever, even when you suspect that there's an infection going on, do a CBC. protein exams. You're going to look at the T cell and B cells, skin test. Look at those as well. You are not going to have to know these immunizations. You don't have to know the immunization schedule. You don't have to know anything. Just know that these are the most common immunizations out there. And then this is just a link to the CDC website as well, but you're not going to have to know an immunization schedule for this all. Does anyone have any questions right now with the introduction chapter before we get into let these slides load up? Okay. There's not as many disorders in this chapter. Some of this, or a lot of this, we've already discussed probably in fundamentals of pharmacology when we talked about allergies. So a lot of this is just going to be review. There are going to be some new things, but a lot of it's just mainly review. So we already know what an allergic disorder is: a hyperimmune response to a weakened antigen, and it's usually harmless. An allergy is usually harmless. So it's characterized by allergies that gains entry to the body, the allergens and antigens that cause an allergic reaction, and an allergy, as we know, can occur at any age. Types of allergies, we've already been through this. You have ingestants, contact allergies, injection allergies, and this is just some examples of different types of allergies that you could have. Allergic rhinitis, contact dermatitis, like I said, food allergies, urticaria. Angioedema, as we know, is life-threatening, correct? Angioedema is a life-threatening allergic reaction. This is just a visual for you guys that like a visual of types of allergies. Like I said, we've already been through this several times. So sometimes your exposure to an allergen does not produce any symptoms. We've already talked about that. You may have a delay type reaction. Allergies are grouped into types. We're not going to have types on your test. I don't intend on you memorizing the different types of allergy levels. But this is just how it's broken down into those allergy disorder types. And then here's just another visual of the same thing that just kind of shows you the breakdown of that. You have the delayed hypersensitivity, so that may take several hours to a few days before the person has an allergic response to the medication. We've talked about that in the past as well. The delayed allergy. So know that an allergic response can be localized, can be temporary, and it can be life-threatening. It becomes life-threatening whenever we see it in the form of anaphylaxis, which we have talked about in the past. And that can be, anaphylaxis can be from a cause, a variety of things: food, medications, toxins, insect bites. You have the angioedema that can occur, hypotension. You can have swelling in the face, neck, larynx. Maintain their airway. That's the most important thing when that person's having an anaphylactic reaction. So how does a reaction occur, the mechanism? So this is just how the cells respond to that allergy once it starts. This is a mechanism of an allergic reaction. Eosinophils, they come from the mast cells. Chemotaxis, that's a particular area in the body. Epinephrine, we want that release of epinephrine because we want to try to get that allergy under control. Corticosteroids, you want to try to give some steroids to help reduce that inflammation. Like I said, we've already talked about allergic reactions and what they look like, so we're going to skip over this because you've already seen some of this in pharmacology. But then again, how do we diagnose allergies? So we may do a scratch test or a prick test. With the scratch test, we've seen some of that, and that's done on the back or on the arm, and you're injected with a small amount of the allergen, and then the nurse or the physician reads that to see if you've had a positive reaction to that test. So whenever you're doing a scratch test or prick test or the RAS test, any type of allergy testing that can invoke or can make a reaction or allergic reaction occur, make sure that you've got your equipment readily available in case that person develops an anaphylaxis reaction. So make sure that you have your emergency equipment there, your oxygen, your medication like your epinephrine, whatever you've got to do to reverse that allergen, because you want to make sure you have it close by, because you never know, during that simple scratch test or prick test that you're doing, that patient may have an anaphylactic reaction. So make sure that you have your emergency equipment there all the time whenever you're doing your diagnostics. So what kind of treatment are we going to use for any type of allergic reaction? Drug therapy is going to be one of the first things. Of course, you're going to have oxygen on. A lot depends on where the patient's at. If you're just at the doctor's office or at the clinic, you may or may not have access to IV to get that started. But you may have some Benadryl or some Solumedrol, some type of allergic reaction medication that you can give. They can give Benadryl, diphenhydramine, some histamine blockers to get that under control if need be. Epinephrine, always have epinephrine available for those allergic reactions as well, and you're just going to give that IM or IV or sub-Q. Nursing management for someone who has allergies. You have that patient, they come into your office or your clinic, you know that they have known allergies, so what are you going to teach them about that? So if they feel that they're having an allergic reaction, they need to, remove those watches, rings, whatever, to take that off because of the swelling. Make sure that they carry their EpiPen with them. Teach them how to use their EpiPen. Teach them avoidance therapy. Make sure that they're using mopping on a regular basis or dusting on a regular basis to decrease those allergens in the household. Avoid certain products that may contain allergens such as latex. You want to make sure that they're reading labels, avoiding those type of products, and know to administer antihistamines like we talked about. Benadryl, make sure that they have their EpiPen, and if they need further assistance, make sure that they are able to call 911. And these are just a list of some of your common medications that can be used for treating your allergies. Like I said, the allergy part, we've been through this before in pharmacology. It's some of the same stuff. But now we're going to talk about some of the autoimmune disorders. Does anyone have any questions about allergies before we move on to the disorders? If you've got any questions, just let me know. So, an autoimmune disorder, diseases are considered autoimmune when they are characterized by unrelenting progressive tissue damage without any variable etiology, so you may not know the cause. Some examples of autoimmune disorders. This is just among the ones we're going to talk about. You can have hemolytic anemia, multiple sclerosis, myasthenia gravis, ulcerative colitis, rheumatoid arthritis. These are some common autoimmune disorders that you may see. Like I said, the cause, tissue injury is a theory, infection trauma. Some medications can induce an autoimmune response. Some infections may introduce an autoimmune response as well, such as your staph infections. It could be genetic in nature. That could also cause the autoimmune response to cause the disorder. Symptoms depend on the tissue and organs that are affected. And symptoms are characteristic of an acute inflammatory response. So the patient may have a low-grade fever, malaise, fatigue, weakness, weight loss. They may have exacerbations, so they may have periods when the signs and symptoms are worse than other times, and they may alternate with periods of remission. And the duration of exacerbation and remission is unpredictable, and the duration and length of exacerbations and remission is unpredictable as well. And it varies very individually, I should say. It's a very individual process. Not everyone will have the same remission period or exacerbation period at all. So it just varies from person to person. So that's why diagnostics for an autoimmune disorder can sometimes be a little difficult. But we're going to look at the erythrocyte sedimentation rate, which is your ESR. You can also look at your anti-nuclear antibody titers, and I'll look at your rheumatoid factors. So as you see, as far as your medications go, immune suppressive drugs, cytotoxic agents, and corticosteroids. These medications have a tendency to reduce or impair a patient's response to infection. So whenever they're taking these medications for an autoimmune disorder, they are at risk for infection. So if you think of something right now, anyone who's taking these medications right now are at risk for what? What's going on right now that makes them at risk? Yeah. If it lowers their immune system.
Coronavirus.
Yes, COVID. So if they're taking these medications, it will weaken their immune system, so they could be at risk for developing COVID. Exactly right. That's what's going on right now. So when they talk about those people with a weakened immune system, it could be any of these people with an autoimmune disorder, and they could be taking either one or a combination of these medications, and that's going to weaken their immune system. So whenever you're doing your nursing assessment for these patients, you need to make sure that you have a really good history. Like I said, they don't know what causes some of these. So is it genetic? Well, some of them they don't know. It's still have been, investigating, still doing a lot of testing, still doing a lot of that kind of thing to see. So make sure you have a good family history. Vital signs. Examine the patient for signs and symptoms of localized inflammation. You'll see that with the rheumatoid arthritis. Assess the patient's level of energy. Review those lab findings. So like I said, those certain labs that we're going to draw, we're going to repeat those frequently and just monitor that patient with that. Your nursing interventions will be encourage them to rest during those periods of exacerbation, but they need to get some regular exercise, especially during those periods of remission, stay active as much as possible. Offer some non-pharmacological pain management strategies as well. So chronic fatigue, we're going to start with that. The person is extremely tired, overly, more so than normal. There's no identifiable cause. Fatigue worsens with physical activity and does not improve with rest. No cause is yet to be established. So a lot of this, you're just going to go on the patient's signs and symptoms, the complaints. You're going to do those lab work and maybe get the patient to the days or the times or whenever they're feeling the worst. Make sure that the patient's taking some really good journaling notes to bring into the office so that you can review. Could also be deficiency in your ATP, or it could be caused by a virus. The cause of chronic fatigue is unknown. The patient has a flu-like symptoms or upper respiratory infection that's recurrent with sore throat, muscle pain, joint pain. If it is severe, it can be debilitating to the point where the person may be in the bed most often. And this is just more of your diagnostics and nursing care. Like I said, the medical history. Can do some blood tests to work up with that. And then as the nurse, we're going to help with their ADLs, schedule rest periods, help them with their pain, whether cold or warm compress, encourage floating in the tub or pools. That can help with their pain level as well. So the outcome, you're going to help with the patient's pain level. It's not going to completely go away, but it's going to be tolerable for the patient with chronic fatigue. Lupus. Affects the connective tissue. The systemic lupus is a connective tissue disorder, and it can also affect the multi-organ system. It can even lead to major organ damage. Some of the lupus can be induced by medication. These are some of your more common medications. And once the medication is discontinued, lots of times this lupus will resolve itself all in. Women 20 to 40 years of age, African American, Asian, Native American, these are the most common affected by lupus. Declines in females following menopause and is unchanged for men. There may be delayed treatment in the elderly because a lot of the signs and symptomatic conditions that are common with that age group. So findings. Expected findings in a patient with lupus. When you do your assessment, this is what you're going to find. The patient complains of fatigue, alopecia, blurred vision, pleuritic pain, weight loss, depression. They may even have, it's called a butterfly facial rash. You may see that on the patient, a butterfly facial rash. They may have fever, Raynaud's pericarditis. May even develop some organ failure. So how do we go about diagnosing lupus? Skin biopsy. Going to do some blood tests, some ANA titers, ESR titers. You're going to look at that BUN and creatinine because you're looking at renal function. A urinalysis, CBC, going to look for any signs of infection. As far as care for that patient, we're going to monitor their pain level, help them with their mobility, assess them their fatigue, vital signs, look at their urine output, their breath sounds, all this typical stuff that you're going to do, lab values, nutritional status. They do better with small, frequent meals, limit their salt, provide emotional support, and assess the patient for risk of pregnancy. A lot of that has to do with some of the medications that they may be taking, because we're going to be getting into the medication next. Some of the common medications you're going to take, once again, here we had medications that can weaken the immune system, your steroids, your suppressant agents. These can weaken the immune system, so that person could put the patient at risk. Any questions about lupus? Okay, so we're going to move on to gout. So gout is an intra-articular uric crystal deposit that causes an inflammation. I'm going to type that out. Let's see if I can find that. You guys see that?
No, ma'am.
You see that? Well, dang, I wonder why.
Oh, we see it now. It's delayed.
Oh, okay. All right. Yeah. I hadn't quite figured out how to make this go back to the slide I was at, so just bear with me. All right. So, yes, gout, most common inflammatory arthritis, a disruption of the purine metabolism, where uric crystals are deposited in the joints and the body tissue. So primarily, primary gout is the most common type. It does have possible genetic components. Uric acid production is faster than excretion. Middle and older age adults, males, it usually peaks age 40 to 50, and women, they usually see it postmenopausal. With your secondary gout, it's caused by another disease or condition. The treatment is based on treating the underlying condition, and this affects all ages, your secondary gout. Risk factors: obesity, cardiac disease, trauma, alcohol, starvation diet, some chemo agents. So here is like your secondary cause. So if you got rid of the chemo agents, then it may resolve itself. Chronic kidney failure. Findings: severe joint pain. Yes, very severe. Usually in that great toe, believe it or not, those people, you look at their feet and that great toe will be just red, swollen, warm to the touch. Very, very painful, very painful. And it may have the appearance of tarpi, which is like crystals on the outside. You may see some of that. So for your nursing management and medications, of course, you're going to monitor the patient, look at their pain level, assess the redness and swelling in the affected joint, and you can look at their serum uric acid, which is, some blood work we can draw and look at that. Lots of times they'll give colchicine or NSAIDs, sometimes prednisone as well. If it's chronic gout, they may be on some allopurinol. You'll see that lots of times given regular basis for those people with chronic gout. Any questions about gout? Okay. So we're going to move on to rheumatoid arthritis, and there's just a few slides with this. But rheumatoid arthritis, you'll see a lot of deformities. This is a late stage arthritis that you may see. The swan neck deformities in their fingers, the boutonniere deformity in their thumbs, deviations of these phalangeal joints. You'll see those deformities there as well. Make sure you know the difference between boutonniere and swan neck deformities. Hint, hint. Everybody got that? Some of the lab work that you can draw: C-reactive proteins, your ANA, CBC, rheumatoid factors. They can do some x-rays. They can draw some fluid from those joints and test that as well. That's just part of the diagnosis of rheumatoid arthritis. Nursing care: apply heat or cold, assist with activity, monitor for fatigue. A safe environment. Help them with their medications if they need it. Nutritional teaching will also help as well whenever you're talking about your rheumatoid patient, because you can imagine if your fingers are painful and they're swollen and they're deformed, how hard it is to open the knob of a door or open a jar or something like that. Just daily things we take for granted, how difficult that is for someone with those types of fingers doing that. Some of your medications, procedures, and complications. These are most commonly used. They're going to use some steroids and NSAIDs. to do some joint arthroplasty so they can go in and repair the joints if they need to. They can do that. They can develop some osteoporosis as well with the rheumatoid disorder. Any questions about the disorders of the immune system? Before we move on to chapter 5.
I kind of have a silly question.
Well, ask it.
So, how do you know whether to apply heat or cold? Like, is it just an alternate thing, or is it specific to
It's just
something?
whatever the patient prefers, or whatever's going to help the patient feel better.
Okay.
It's just a personal thing for the patient. Do you want me to put some ice pack on it? Do you want us to try some ice? Or would you like for us to try some heat? Which would you like for us to try first? So, it's just one of those things. It's just a personal preference.
Okay. Thank you.
Mm-hmm. Anyone else got any questions about? Okay. Mm-hmm. Let these slides load. Okay. So, how many of you have been able to watch the documentary 5B yet? I know that some of you have watched it. So, what were your thoughts about those of you who watched it? What are your thoughts about that documentary? If you haven't watched it, don't worry about it. You know that's just part of the assignment. But I was just going to give some folks the opportunity to tell me what they thought of the documentary. Yeah, I have. Someone says it was really good. Someone says it was super sad. You guys, I just have to admit that I cried quite a bit during the movie when I thought about the patients who were having to go through that without their families being there.
I cried a lot too.
Did you? Yes. So I was thinking whenever I was watching it and I saw these people who were dying without their family, without their loved ones, I thought about what's going on with people now. Well, the same thing happened with COVID because guess what? They won't let you in the hospital. So if your loved one's in the hospital with COVID, if they're on the ventilator, if they're in critical condition, you can't be there. And I was thinking, how horrific is that, knowing that that's going on now, and looking back in the early '80s, because this is a true documentary. That's real. That actually happened. That facility existed. That wing in that hospital was there, and I thought it was an excellent movie for you guys to watch, so that you could see where we were in the '80s with HIV and where we are now with HIV. And if someone is HIV positive, how they start that treatment early, the success they have, they can live for years and years with that treatment, that regimen of drugs, if they would just take it and live a long time. The two nurses in the documentary that are HIV positive, I thought that was for them to share that was brave of them to share that with us, to tell us that they were positive. They didn't have to do that, but the fact that they did me.
Do you feel like that's what brought about that no recapping of needles?
Well, that was one of the things about recapping the needles. Yes, HIV is that, but then also you have hepatitis as well.
Right.
But yes, that is one of the things that spurred needleless systems that we use now, not recapping those needles that to prevent that needle stick. That one nurse who did get HIV with the needle stick, but what was his name? I see his face, I can't remember his name. The
You
nurse,
talking
the
about
male nurse.
the African American guy?
Yes, yes.
He was so funny.
Well, he didn't say how he contracted AIDS either. I mean, HIV. He never said. I mean, he's positive, but he never said, how he, contracted the virus. But yeah. So as you see, a lot of that from the 80s, as far as infection control and PPE and all that came about. Changed a lot of things. Changed a lot of things. And back in the early, I should say, in the mid 80s was my first encounters were with a couple of HIV positive people. All right, I read that comment. So this are some links on your PowerPoint that you can click to, but I'm going to try to share my screen so that you guys can see what I want to show you guys. This one, if it will let me share application. Oh, tab. Let me show a tab. Here we go. So as you see in this part of the screen, some of your how it's kind of distributed, I should say. 24% of the population is heterosexual contact. 7% is IV drug use. Then you have a 3% male-to-male sexual contact plus injection drug use. And then your 66% is male-to-male contact as well. Let's see what the next one is. Tab, and I want to share United States. This is kind of how the new HIV diagnosis in the U.S., and this is 2018. So this is just 2 years old, and this is how it's broken down. And these are links that are on your PowerPoint as well that you can go back and look at, and just click on the link. We see men, of course, up at the top. Your African American, male to male, Hispanic, Latino, male to male, white, male to male, African American women, heterosexual contact, African American men, heterosexual contact, Hispanic women, heterosexual contact, and then white women, you're a heterosexual contact. So these numbers are just amazing to me. Every time I look at this, I'm amazed at these numbers, at these statistics. This is just another graph, and it goes by age. As you see, this is just 2 years old. And see the age group 25 to 34. Look at that. The numbers are staggering to me with that. And these are new diagnoses. These are new. These aren't old. These are new diagnoses as well. By region.
Not surprised by Georgia and Florida.
Now you see that Georgia is, you see where we rank. We're here. We're in this this dark blue area here. I like to share this information because I don't think people realize where we kind of sit. You see Georgia, Florida, Louisiana. Look at that. It's amazing. I just like to share this because I like to preach protection. So make sure that you're getting some protection there. That's for sure. But these numbers are staggering every time I look at that. Someone asked a question about PrEP, about the PrEP that you see now as far as treating HIV. As far as treating the HIV, it helps stop the progression of that. Let's see. And a lot of those PrEP products that they talk about are new. So the success rate, I'm unfamiliar with at this time, but that is a good question. And I'll look into that and find some information and try to get out to that.
Ms. Schumann,
Yes.
whenever like they are considered undetectable, does that mean that they won't pass it to somebody or can't?
Oh no. If they're once you're positive, you're always positive.
Right, but I'm saying like you know how like they become undetectable whenever they take the medication regimen. Does
Right.
that mean that they can't, or the likelihood of them passing it on to somebody is like low?
No, they can still pass it on.
Okay.
Yes, even though you take your medication and it's undetectable, you can still pass it on to transmit it to someone else.
Gotcha. I think that's like a misconception. I think that because I know quite a few people with it, and I think that's what a lot of them think. But that's good to know.
No, yeah, they can still pass it. When it says undetectable, it just means that the medication is working and that they're prolonging their lifespan, basically. But the websites that I just linked to, that I just shared with you guys, they're right here in your PowerPoint, so you can definitely link to those and go back and look at that at a later time if you like. AIDS is an infectious and fatal disorder that weakens the immune system. So here once again, a weakened immune system, not by medication, but by a disease process. So these patients are at risk for COVID. So that puts them in that high risk category that they keep talking about. That's it. HIV is a pathogen that causes AIDS. It is widespread. As you have homosexual men, IV drug users, heterosexual women, and healthcare workers are well. Subtypes, I'm not going to test you on subtypes because there's just way too many subtypes to get into. And you aren't going to be tested on that. So you look at your T cells is something that we look at with your HIV. Here is a video that will link you over to the HIV life cycle if you want to see more information about that. But it's a replication, and it just replicates over and over and over and over again. It just gets into that RNA and that DNA, and it is just a continuous replication of that virus. Transmission, body fluids. You're going to have blood, semen, vaginal secretions, and breast milk. Not saliva. Blood, semen, vaginal secretions, and breast milk. This is how it's transmitted. These are the fluids that are involved in transmission. Your high risk factors: unprotected sexual intercourse, multiple sex partners, sharing IV needles. Like I told you guys, I'll give you a needle. Just take a clean needle and please don't share. Non-autologous transfusions, and infection of mother to infant by transmission. Prevention. So you guys know prevention. I'm a big proponent of prevention. You know, teaching our youth to abstain from sex is a little bit difficult. But they get free condoms at the health department. That's all I got to say. Free condoms at the health department. Monogamous relationship with an unaffected partner is a prevention. Avoiding casual sex with multiple partners. Use a condom. No IV drug use. Know that those people who are taking the smoking the meth out there, that increases the hypersexuality, increases the risk of HIV contraction. Use a new needle. Refrain from donating blood if engaged in high-risk behaviors. And you can bank your own blood. We talked about that. You can bank your own blood for future surgical procedures, especially those that are elective. So nursing practice, just use standard precautions. Report any needle with sharp sticks. If a nurse or a healthcare worker, doesn't matter, it can be it can be the housekeeper. Someone threw a needle in the trash can by accident. The housekeeper picked up the bag and got stuck with the needle. So you're going to have to follow the same sexual precautions as someone who's been diagnosed with AIDS while waiting your test results. So make sure that follow your facility guidelines, and that's going to be probably the one they're going to tell you to do. So your AIDS is a fatal infection that weakens the immune system. AIDS is the end stage of the HIV infection. Markedly decreased T cell count. So for a hospital employee that's been infected or has had a needle stick, it usually doesn't take long for a hospital employee's results to come back. They usually can get it back in like 24 hours. But then you need to be tested usually every 3, 6, and 9 months after that. One test is not enough. You have to do it for at least a year. You'll be tested. So your criteria for your AIDS is decrease in T cell count, and certain cancers can develop, and you'll have these opportunistic infections will be present as well. And this is just kind of a little rundown of your HIV to AIDS progression. beginning, it's going to be flu-like symptoms occur within the first 2 to 4 weeks after contracting the virus. Then you have a latent period, and it may take a long time before your a significant infection occurs that would take you to the doctor. And then your AIDS occurs when your CD4 count falls below 200. And you're more vulnerable to those opportunistic infections when that CD4 count is below 200. So the patho and etiology impairs the ability of infected T4 cells to recognize foreign antigens and stimulates B cell lymphocytes. Rate of progression, which kind of HIV, the amount of virus that's in the cell as well, and then that can hinder the conversion of HIV to AIDS. If the drug treatment is effective, that slows the conversion time. So you have an acute retroviral syndrome. So whenever they come in, they'll have fever, swollen tender lymph nodes, pharyngitis, rash, muscle, joint pain, Kaposi's, sarcoma, pneumocystis pneumonia. You're going to see that. A common infection in a person with AIDS is that pneumocystis pneumonia. You're going to see that. Abnormal pap test, pelvic inflammatory disease. So it can be some type of, looks like a virus that you have, as well as pneumonia. So how do we diagnose HIV? So you can do the ELISA test, and that just confirms the presence of antibodies. That confirms the presence of antibodies. Your Western blot is what confirms HIV. This is your confirmation that you have HIV, is your Western blot. That is your confirmation that you have HIV. Positive Western blot. Your viral load and T cell counts are performed every 2 to 3 months in order to determine the progression of the disease as well as guide the medication treatment. The T cell or your CD4 count, that measures the extent of the immune system damage. A viral load, this is the number of viral particles in the blood. But no, before you do your Western blot, before you do that HIV test, you have to have consent. No consent, no Western blot test. A lot of times you'll see patients who may come in, they are positive for, they have everything. They have pneumocystis, they have yeast infections, they have everything going on. They will refuse testing. Lots of times, why do people refuse testing?
Because they feel like they're positive.
Yeah, but why would you fear that?
They don't want to know.
Well, a lot of it can be they don't want it on their insurance.
Oh yeah, that too. Yeah.
That's a big thing. You have that on a life insurance policy. You can't get life insurance.
Yeah.
That shows up on your history, on your medical history. People don't want that on their charts. They don't want that in their medical history. They have it on their medical history. They change jobs. Guess what? They may not get coverage from that employer. Not as employer as it is the insurance company. Insurance company's not going to insure you. So you don't want that in your medical record. So that's a lot of it right there.
So, Ms. Schumann, if they consent to the test and it's positive, does it have to be on their medical record?
Absolutely.
Okay.
Yes. That's part of their medical record because that's just part of the medical record. Any test that you have done is part of your medical record. Yeah. That's going to go there. That's part of your medical record.
So they can't say, I don't want that on my record.
No, you can't. You can't. It's there. But that's why a lot of people not want it done. Life insurance policies, they don't want neighbors to know. They don't want family to know. They don't want friends to know. People have been evicted from their apartments, have been evicted from their homes because they're positive.
Can a life insurance or like a medical insurance policy, can they kick someone off because they find out they're HIV positive?
Absolutely. Sure. They just don't allow you to renew your premium.
But how is that legal?
That's part of the problem. That really is part of the problem. So, if you, for the life insurance, if you have your life insurance already before you're tested positive, you're probably good. They probably aren't gonna, they're not gonna take that away from you. But you can apply for a new life insurance policy. You're not gonna get that. And as far as health insurance goes, if you're covered under that health insurance when you're diagnosed, there's not a lot they can do. But say if you go and work for someone else and you're applying for the life insurance, for the health insurance there, and you start filling out questionnaires, they may put you in a high category where you can't afford to pay that premium on that health insurance. Sometimes they'll just price you out rather than kick you out. They'll just price you out so you can afford it, because they know it's illegal to kick you out once you've been approved. So sometimes they'll just price you out. That stuff still goes on today. It wasn't just in the 80s. It goes on today. I went to a meeting one time at the health department for because Bullitt County has a really large HIV/AIDS community, and I went in and sat on one of those meetings, and to hear about people who are struggling to keep their lights on and to pay their rent and buy their medications was amazing to me. It really was. Medical management. So we're going to give the antiretroviral medications. Going to look at that CD4 count, assess those patients who may be at risk for pregnancy. HIV-associated renal disease can happen, as well as hepatitis B. So the goal of the antiretroviral drugs is to keep the CD4 cell count below 350 and their viral load undetectable. That is the goal of the medication. Like I said, you're going to get, when they're on this medication, the antiretroviral medication, you're going to look at that viral load and that T cell count every 2 to 3 months. So you have to keep up with that lab work. So make sure that person goes and gets their lab work drawn on a regular basis. These are just some of the medication categories that these patients, and they don't just take one pill. It's a lot of medication that these people take. It's a cocktail of sort that they take to manage their HIV. Like I said, keep that CD4 count above 350, undetectable viral load. Know if that T cell count gets 200 S, that indicates AIDS. And sometimes if we have a patient come into the hospital and they refuse to have an HIV test done, we can do the CD4 count. You can do that. You don't have to have consent for that. Especially those you suspect may be positive. And you want to know if they're positive or not because that dictates your treatment, correct? If you don't know that they're positive, it's hard to treat someone.
Ms. Schumann, I have a question. So if you do that, would you still, how can I say, you still wouldn't be allowed to put it in their records because you didn't really get the Western blot test?
That CD4 count goes in their record. But that does not confirm the diagnosis of HIV.
Right, that's what I'm saying. So even with that being in their medical record, that it wouldn't like play a part in
Nope.
the okay, gotcha.
Nope, because that's not a confirmation of a diagnosis.
The medical staff would know, basically, though.
Right. Well, the medical staff would know. Anybody who looked at the medical record would know the CD4 count, but that is not a confirmation of HIV.
Right, I understand that.
Right. Right. Somebody just asked me a question. Somebody asked me a question. What was that? Okay, so your medications. Okay, some of your opportunistic infections, one of the most common ones is going to be the pneumocystis pneumonia. The PCP is the abbreviation for that. The next thing is going to be candidus, or your yeast infections. You can see a lot of that. Those type infections, whenever you're taking care of the people with HIV, or basically they're AIDS by now, you'll see that type. And that candidus can be, sometimes you'll see that in their mouth. It'll cause a lot of mouth ulcers as well with that. We'll do stool testing for ova and parasites, and we're going to also look for protozoans because these are all opportunistic infections that you'll see with the HIV patient. There is age dementia, so they'll have some cognitive disorder. It affects their mood and motor functions as well. They may become a little bit confused and forgetful as it progrades into the HIV encephalopathy. But they'll have, sometimes you'll just try to give them some medications to help prolong that, like some Namenda, like we do for dementia patients now. But it's not uncommon to see that as it progresses. Health teaching, that's the best thing you can do is your health teaching. Diagnostics, you have to teach that patient they've got to take that medication every day. They've got to be faithful with taking the medication. They have to go to the clinic. They have to get those labs drawn. They have to be just very religious about taking their medications. So risk reduction and teaching, that's our goal. Reduce the risk of for the patients and for their significant other, whatever. Reduce occupational risk, that would be our risk. Our risk as nurses, our risk whenever we go in. So human touch is important, I believe in that. But know that if you're going to go in and you're going to be pulling those sheets back, if you know that that IV is leaking, if you know that there's possibly incontinence in the bed, if you know these things, then you need to make sure that you put some gloves on. You need to treat every patient as you're walking into the room like they are HIV positive. So that's how you need to think about that putting those gloves on whenever you're going to give an injection, putting some gloves on when you know you've got to put a pill, pick up a pill and hand them their pill, put it in their mouth. Even though it's not transmitted by saliva, you still need to make sure that you are handling that with care, because they may have a fungal infection in their mouth. So you need to be careful about that transmission. Make sure that you're treating every patient as such. Be sure that whenever you're collecting your specimens for every patient, treat every specimen like it's an HIV positive patient. Make sure that those containers are sealed up, those biohazard bags are sealed up. Make sure that everything is sealed up and leak proof. Remove any, if you've got your yellow gown on, make sure that you're removing that properly. Make sure that you're throwing those gloves away in the appropriate container. And like I said, you make sure that you're teaching that patient about their medication regimen, maintaining the weight, make sure that they're using those supplements that they need to so they can keep their weight up, avoid their exposure to people with infections. And so here we talk about that ethical, financial and insurance implications, fear of disclosure. That's why. This is why they don't want it on their medical record. How is it going to affect their employment later? So you beneficiary on their life insurance policies. Sometimes they may have to cash those in to get some money. Might not be able to get any more life insurance after that. So there are true ethical issues going on with the, and that still goes on today. This is not old stuff. This goes on today as far as putting that diagnosis on your medical record. You run these risks. So has anyone taken a look at the HIV case study that you guys are going to be doing? I know some people have, because I've gotten at least one or two questions about that. Yes, yes, good. So that patient, because I read the scenario, she does not know that she has HIV when she goes to the hospital. When I read that scenario, it reminded me of a patient I took care of just like that. She came to the hospital because she had they were admitting her with pneumonia, but when we looked at the chest x-ray, she had full-blown pneumocystis. She had never had any other signs and symptoms up until she came into the hospital. So when she was admitted to the hospital, she was in full-blown, we might as well say AIDS, because we ended up intubating her, putting a chest tube in, central line in, and I ended up flying her out probably after she'd been in our ICU for about 48 hours, but she had been in the hospital out on the floor probably a couple of days before she got transferred to the ICU. She was extremely critical. So when I looked at your case study that y'all are going to be doing, that patient goes into the hospital not knowing that she's HIV positive, but she comes back with a chest x-ray that has pneumocystis pneumonia. So she's pretty much, and I believe her, correct me if I'm wrong, I think it's Alicia who's Allie, the CD count or the T4 count, what was that on that? Do you remember what it was on that patient's lab work? Yes, it was below 200. Yep, it was 189. So just think about putting all those things together whenever you're doing that case study. I think it was pretty interesting case study once I read through it. But yeah, do you guys have any questions? So one more thing before we wrap it up. The final exam opens up on May 4th at 12:01 a.m. Let's see. Whiteboard. I'm going to be typing here, guys. Okay, so the final exam, which includes these last 3 chapters, will open on May the 4th at 12:01 a.m. and it closes on May 5th at noon. So everything needs to be turned in. All your Prep U needs to be done, all your ATI needs to be done, all your pharmacology made easies, everything needs to be done, because after you take that final exam, the following day we're turning grades in. The grades are going to be, we'll turn those grades in. So in order for us to have those grades turned in, everything needs to be done so that we can have them turned in on time. Any questions? And I look forward to seeing you guys next semester. I think I'm doing 1 lecture, but I look forward to seeing you guys in the summer. And I'm don't know about you guys, but I'm ready for a break. Yes, your grades will be on Blackboard. Yep. So I'm going to try to get those case studies, discussion boards. I got a few things that I've got to put in, but as soon as you're done with your final exam and that grade post, if you see that I've done all your other grades for that course, I've already put them all in the Blackboard, and that's your final grade. Anything else, guys? Yeah, so if you have any questions or if you need anything between now and the final, let me know. And I'm always available. I'll be available over the break at some point in time. If you just want to shoot me an email or something, if you have a question, just let me know. I know Ms. Conley has already posted you guys a tentative checklist for summer. And you got this, that's for sure. Anything else, you guys? If you have any questions, let me know. Some of the work will be open early, yes. We will have some of that open. I do believe that the first thing you'll have is going to be GI, and I think that Ms. Conley was going to be sending out that information for GI for you guys to start on that. Yep. I want to think that she's going to send out some GI stuff for you guys. If you hadn't already got that email, she should be sending that out soon. But you may already have that. And we'll just make sure that the assignments and everything else are open. I think more than likely everyone's going to get those 5 points, especially if they've done all the work. That's probably how we're going to end up doing it. So that may change next semester. I don't know. We hadn't got to the syllabus yet, so hopefully we'll get to that syllabus over the break and get that posted up. But as far as I believe that 5 points will be added to the final grade. Anything else? All right, guys. So we'll just be calling this to an end, and I will be posting this on Blackboard as soon as it's ready for me to post, and then I'll let you guys know when it's up. You're quite welcome. You guys have a wonderful day. I miss you guys too so much. If you only knew. Y'all keep me sane. All right, love you guys, and y'all take care. And I look so much forward to seeing you next semester.